My name is Warren McAdams. I'm a doctor of physical therapy, and I wanted to discuss spondylolisthesis and spondylolysis. These are two conditions that clinically manifest themselves as lordosis, most commonly. Lordosis is something that refers to an increased bend in the lumbar spine and sometimes is used in reference to increased curvature in the cervical spine. Occasionally in literature and from other clinicians, I will hear it used in reference to the thoracic spine and the reduction of the natural kyphosis that should be present, but because of the confusion it can sometimes elicit, I don't know that that's entirely appropriate. But I think it's important to appreciate the fact that a lordotic curvature to the cervical and lumbar spine is normal. Lordosis in itself is not necessarily detrimental because we gain a mechanical advantage by having some lordotic curvature to those parts of our spine, so long as it's counterbalanced by kyphosis in the thoracic and sacral spines. So it's not uncommon that we see an accentuation of lordosis in typical child posturing, especially when a toddler is introduced to walking, as it's the first time in their lives that they experience this axially loaded gravity throughout their entire body, from head all the way down to their toes. So that newly induced lumbar spine curvature is normal. It should diminish though by the time they're about 8 years of age. And when we are discussing lordosis, there are conditions like various muscular dystrophies and so forth, which predisposes a child to prolonged sitting, which can cause a hip flexor contracture. Most of the time that'll be bilateral, but the result will be a compensatory lordosis. And there are other conditions like myelomeningocele, for example, where a child may present with increased lordosis as a compensation to their altered gait pattern. However, one of the most overlooked common pathological reasons I see lordosis in my particular pediatric setting is due to spondylolysis and spondylolisthesis, both of which are subtyped based on what causes the displacements and their etiologies. There are 5 categories. We have dysplastic and isthmic, which are by far the 2 most common seen in pediatrics. Then you also have degenerative, traumatic, and pathological. To put it simply, degenerative is most commonly what we see in geriatrics as a result of age-related degeneration of the spine. Traumatic typically arises from fractures of the vertebrae with pars interarticularis sparing, and the sparing of the pars interarticularis is quite important to note. The pathologic is seen in cases of infection where there is a destruction of one or multiple vertebrae, and that can cause that spondylolisthesis. But I do want to elaborate on dysplastic or isthmic classifications given their increased prevalence. For dysplastic spondylolisthesis, it is commonly seen by clinicians in the NICU, the PICU, or in the home health settings, because you are more likely to see congenitally acquired spondies in cases where the bony malformations, especially those affecting the facets or the superior articulating surface of the sacrum, where it is the base of support for the L5 vertebrae, kind of enables it so that there is instability at those segments. You can also see spina bifida, for example, where there is a notable reduction in the posterior form stabilizers. So essentially bone-on-bone congruency issues or hypoplasia can lead to easier slippages. Ultimately, this can lead to a significant anterior displacement of the superior vertebrae, most commonly L5 in relationship to S1. And what's notable is that this can cause a compression of the spinal cord within the spinal canal, thereby eliciting neurological symptomology at and distal to the level of the lesion. So again, that's dysplastic spondylolisthesis. And when we move on to isthmic spondylolisthesis, it's seen a lot in the outpatient orthopedic setting or the pediatric sports orthopedic settings because you see so many young athletes exposed to these repetitive hyperextension biased activities, especially when it's coupled with a rotational component. So for example, volleyball. And if I had to though give one poster child for someone that experiences these Isthmic Spondylolythesis, it's going to be a female gymnast going through puberty. So you have the ligamentous laxity as a result of the female to male, and then you have bodies growing and stressing structures that are not normally stressed upon when you're going through puberty, and then you have the occupational effect. They are purposefully bending into extreme extension and rotation, and they're bouncing all over the place, and this can cause a lot of strain on that pars interarticularis, and that may finally give out, and the structural integrity of that pars interarticularis no longer may be appropriate, and this may be as a result of one macro trauma leading to a fracture, or it could have been micro fractures over time leading to slowly continual remodeling of that pars interarticularis into an elongated position, thus enabling an anterior slippage. Now there are 5 classifications of spondies, and you might still be asking, well, we just went over those 5, but you might be wondering, I still don't understand what the difference between a spondylolysis and a spondylolisthesis is. Simply put though, a spondylolysis indicates a structural integrity loss, whereas it precedes a spondylolisthesis, where there is an actual slippage or anterior displacement of one vertebrae on top of another. But it is important to note though, technically the slippage doesn't have to be anteriorly like I keep describing. That is an anterior listhesis. We can also have a retrolithesis where it slips posteriorly, and that's the superior vertebrae slipping posteriorly. But that doesn't really produce lordosis, which is kind of the focal point of this lecture. So my referencing will continue to entail an anterior slippage of the superior vertebrae. Now, in relationship to the slips, how do we grade this? It's typically on a scale of 1 to 5. 1 describes a 0 to 25% anterior displacement, 25 to 50% would be a grade 2, 50 to 75 would be a grade 3, 75 to 100 is going to be a grade 4, and finally your grade 5 is a complete fall off. There is no more contact between the inferior surface of the superior vertebrae and the superior surface of the inferior vertebrae. It's completely gone. So as you can imagine, compression on the spinal cord increases as the severity of slippage increases, and this can produce local and distal pain and weakness, which may be exacerbated with any activity that increases that anterior slippage. So the patient may find more comfort when they're sitting down, when they're remaining still, not really moving anywhere, doing anything. The cord compression can also induce a loss of bowel or bladder control in the more severe cases, but this can be difficult to identify in the pediatric population, as that child may or may not have already been potty trained. So outside of that, you can also see additional implications of the hamstrings. They may be at a deficit as a result of the neural compression, so they might have spasms, might feel tight, and of course there may be an increased lordosis, as I've mentioned on and on again. However, in severe slips, we have not touched up on this yet, but in a severe slip, the sacrum will fall more vertically, and as a compensation, you will have more of a reduced lordosis. So it'll be a bit of a flatter spine, contradictory to what a lot of folks might be under the impression of. However, when you do have that slip forward and the spine straightens, you will have a nicer step off or a a spot on palpation that you can feel the bump, and that's the inferior vertebrae. So if you're seeing these signs or symptoms in your patient, it's pretty imperative that you go ahead and refer for radiological imaging. Based on the findings, surgical intervention might be recommended, most commonly if there are existing neurological symptoms already present. They'll go ahead and go on with surgery. In that case, the surgery might be a posterior arthrodesis. If the condition is a little more progressed and the slippage is a little more anterior, then they might do an anterior arthrodesis or even a circumferential fusion. But at times when surgical intervention is not quite yet appropriate, but conventional PT might not do all that it needs to do, particularly in cases where on X-ray imaging you do still see a pars interarticularis visible fracture, you may go ahead and recommend that patient follow through with the TLSO while the bone heals. And nobody likes to be in it, but it can be quite influential in maintaining the integrity of that spine. But what can we as PTs do outside of recommending for a TLSO or surgical intervention? The convoluted answer is to simply address deficits or deviations from norm found during our assessment. Often I assess obvious postural alignment and spinal flexibility, strength and range of motion of the trunk and lower extremities, functional movement patterns like seen in ambulation or stepping and so forth. Particularly though, I hone in on weakness of the abdominals and the low back to see if the integrity of those muscles are capable of firing both independently and or with co-contractions. Most likely, these will perform a bit poorly, and the resultant pelvic positioning and alignment will also be quite poor. Because the hamstrings and the gluteal muscles are commonly implicated due to the earlier mentioned neural compression, I also pay close attention to their performance as well. We may want to strengthen those along with the back extensors while the patient is in a more appropriate, ideal alignment, whether they're in supine, prone, or standing. So essentially, this results in us doing what we always do. We stretch what's short, we strengthen what's weak, we improve alignment, but we really hit hard the piece on educating for function and ideal movement patterns with appropriate postures and positionings. My personal rule of thumb when I see lordosis in general is to go ahead and strengthen the lower abdominals, to encourage co-contractions with the gluteals and to strengthen the low back while I emphasize pelvic tilting and ideal postural alignment. But in cases where the lordosis is compensatory as a result of hip flexor contracture and I see a bilateral knee bend, you're probably going to be thinking the hamstrings are going to be a bit short. So in that case, I'd go ahead and definitely stretch those as well. But perhaps at a later date, I'll make a video for home exercises in relationship to how I would treat a spondylolysis versus a spondylolisthesis versus another etiology that would produce lordosis. But for now, I'm going to go ahead and draw to a close. If you appreciated this content, please like and subscribe. Feel free to provide any comments for constructive feedback. It only makes my future videos more influential and helpful to you as an audience member. And also, please feel free to offer up any videos or ideas that you would like me to make in the future. And I hope you have a very wonderful day and continue to learn as much as you possibly can.